Good evening, ladies and gentlemen, and thank you, organization, and me to talk on diffuse large B-cell lymphoma approaches based on the recent advances. In this talk, I will go through the update in the ASH, ASCO, and EHA 2021, what evolving treatment in the DLBL, and where we do stand in 2022. In next 20 minutes, I will take you six main steps, eye opener, DLBL journey, challenges and their solution in 2022. What is the new in first line DLBL overview of the ASH, especially 2021 data, POLARIX pivotal trial, then advantage of POLA in the DLBL, and my question is how do you predict DLBL in 2022 to 2025? So just this opening question, challenge, which treatment strategy would you like to recommend for a patient with very high IPI score, ABC, DLBL lymphoma? So what do you think? The standard, I think everybody will think about R-CHOP versus Dose-Dense R-CHOP. Let's see what guidelines say. So which guideline you use to treat DLBL? People use different guidelines from ESMO to NCCN, and our part of the world, we use actually NCCN guideline. So this NCCN guideline saying stage 3 and stage 4, you have two choices, either R-CHOP or clinical trial in these type of patients. So what we should do, going back to the patient, so either we choose this one or we can go for clinical trial. But the good thing is 2021, 2022, something has new come, which has emerged after 3 decades, something beyond the R-CHOP. This is the topic we'll discuss today, POLA R-CHOP. Now, to make summarize it, how I treat DLBL, I will go through the first A to G hits of the lymphoma. First step is accurate diagnosis, and B is beyond the R-CHOP, especially in high IPI score patient, and what treatment is convenient and least drug toxicity and feasibility and guideline. So first I will go to the background of DLBL. So basic, what is lymphoma? Lymphoma is a cancer of lymphocytes, and it's divided basically Hodgkin and non-Hodgkin. And who was the Hodgkin? First, Thomas Hodgkin, who actually developed Hodgkin lymphoma, and who was the Reed? This is the Reed Sternberg cell he produced. So these are two people actually divided Hodgkin versus non-Hodgkin lymphoma. Now, today we are talking non-Hodgkin lymphoma, especially DLBL. This is the 5th leading cause of cancer death and 2nd fastest growing cancer in terms of mortality. Lifetime risk of lymphoma is 2%. Exact international prevalence is unknown. However, male is more predominant, 4:1 ratio, and DLBL is found 25 to 30%. Rest is found lesser in the lymphoma. So how they present in the Europe, 4 per 100,000, increase with age. Risk factor usually is family history, autoimmune, and infectious disease. So A is accurate diagnosis. As I mentioned, A, you have to review the slides and blocks, preferable excisional and incisional lymph node biopsy, and if you are available to check ABC or GCB type. And this is the checklist which we use for our first time when patient come into our clinic: physical exams, LDH, B symptom, chemistry, PET scan, we do all these things. So how do we stage? Again, old category N arrow staging, stage 1 to 4, A without symptom, B with symptoms, and then again they are categorized based on the IPI score using, we use formula Apple, A for age, P for performance status, L for LDH, and E for extranodal disease. So anyway, the number of factor, if it's 0 to 1 is low, the risk you can say survival is 90%. If intermediate, it is about 70%, and less than 50% if you poor category. Currently, we are using Hans classification. This is based on the CD10. If it's positive, it's divided into GCB. If it is BCL6, again, if it is negative, then it's called non-GCB. Again, you can see the graph. It makes a difference in the survival. The lowest survival is in the ABC, and the highest survival is the PMMBL, and in between is the GCB. Again, WHO classification also divided into whether the bloster type of typical diffuse large lymphoma is here. Other you have to check it's double hit or triple hit. It's very important to make an accurate diagnosis and staging. So uh, before starting treatment, another important thing in DLBL is you have to identify the patient high risk of CNS relapse based on again, these 6 factors you put in the computer. They will tell you which patient is a high category for CNS prophylaxis. So you have to aid IT chemotherapy or high dose methotrexate. So again, the double hit and triple hit, they have lower survival as compared to the a normal patient. So this is very important to make accurate. So this is accurate diagnosis, strategies, and prognosis. Then we go B beyond the R-CHOP for DLBL. What is the next? If you go the history 40 years ago, all the things were tried, CHOP versus different regimen, but they first found CHOP was the good standard. And even they edited something, they found CHOP is also good. They tried autologous transplant, CHOP is the good. And eventually 2.5 decade ago, the rituximab came, and they actually caused paradigm shift. First time CHOP leads by the R-CHOP, the R-CHOP become a standard, but this is more than now 2.5 decades, and we are far away. We don't have any standard beyond this. So the people are trying what is the next for beyond the R-CHOP in DLBL. They're trying to adding something like Revlimid, Velcade, Ibrutinib, Bevacizumab, Gemotuzumab. They're adding everything, dose regimen, or epoch, and so many things are there. So far, none of them have shown the benefit than the R-CHOP with some toxicity as well. So R-CHOP is the standard. That's why if you open the ESMO guideline, they mention the R-CHOP is a standard from even less than 60 or more than 60. And even in the NCCN guideline, as I mentioned, first line therapy, depending on the bulky, non-bulky, again, R-CHOP plus minus radiotherapy, only the people who are something very high risk, they say, okay, give dose adjustment, epoch chemotherapy or dose and R-CHOP again, but this is not so standard, it's common there. And if the patient is frail, you can give mini R-CHOP chemotherapy. So it means we have unmet. One size doesn't fit to all. Why? Because you see the outcome of the diffuse large B-cell lymphoma, it is really disappointing. About 30 to 40% people have relapsed and refractory non-Hodgkin lymphoma, DLBL. So these are the people who have not given the proper treatment. So far, 3 decades, we are just giving R-CHOP, but we don't have any standard of treatment. And even when relapse, you can give high-dose chemotherapy, autologous transplant, but that is also not a good outcome because 50% again relapse. So this is an important thing. Now, if we open the ASH 2021, is there any new thing is coming? Is the first line treatment. There are 3 randomized trials this year presented actually. First one is the highest one is the POLARIX trial, which is based on the 800 patient, which I'll discuss shortly, 879 patients, sorry. And they have shown 7% benefit of the PFS in the experimental arm. Then other trial was dose adjusted epoch or plus minus venetoclax. They have shown actually treatment-related mortality, so this was also not good. And third trial was based on the tafasitamab. This is actually first line trial. This is also phase 1B actually trial, very short number of patients, only 66%, 66 number of the patient. So the best one trial, which was present in first line, is the POLARIX trial, which we discussed. And other trial, which is also first line single arm studies actually, and these are very small number of patients, 34 and 79 patients, based on the one, ecallabrutinib, other is ibrutinib. They have shown some benefit again, but it is dismal. And then third is actually single arm study, again, diffuse large B-cell lymphoma. Here you can see is CAR-T therapy. This is phase 2, and then other also geloturmab also, they have shown also great benefit. So other studies are non-prospective studies, which are actually real-world experience. They presented some people use high-dose methotrexate and other prophylactic high-dose methotrexate. This also shows no difference of the benefit. So What is the new treatment option now? DLBL. We have ADC based like Pola and other monoclonal antibody, and then you have tafasitamab, then Seluxnor, then by treatment, Belina and CAR T cell therapy. So you have five things, but we have clear shown benefit with the Pola based Polaric study, which is now FDA approved, and also CAR T cell therapy, but this is beyond the second line therapy. So now what is the Pola? Actually, polatuzumab actually is ADC targeting CD79B on the mature B lymphocytes, including DLBL. Here you can see the structure of the polatuzumab. It binds to the ctDNA, it causes the internalization, and then it is called apoptosis of the cell. This is how they damage the lymphoma cells. Now, this is a very huge study. Actually, it's double-blind study. Neither patient knows nor investigator knows which patient is taking actually Pola and which patient is taking placebo. So this is one-to-one randomized trial. One is R-CHIP plus Pola, and other is standard R-CHOP plus Pola placebo. So, and then after 6 cycles of chemotherapy, they will take 2 more cycles of rituximab. This is something Europe, they always give 2 more rituximab as well, so they will go to 8 cycles actually. So they are clearly this is randomized trial, equally divided in both arms as per standard. From you can see from age point of view, gender, echo performance status, IPI score, bulky, non-bulky, LDH, bone marrow involvement, staging, external sites, histological diagnosis, double expressive lymphoma, all are equally divided. And important thing which I will show you here, you can say double expressive lymphoma was included more than 400 patients. It's very high number. So we'll see now what is the safety first. Overall safety profile of Pola R-CHOP is similar to that of R-CHOP, consistent with the known risk side effect. And drug delivery favor the Pola R-CHOP versus R-CHOP, we show shortly. So what they show actually, as I mentioned, the PFS is important in DLBL. Here you can say the PFS with the Pola R-CHIP versus R-CHOP, it is about 7, the hazard ratio is 0.73. It means 27% reduction of the death. So it's increase the PFS about 27% if you give Pola and remove the vincristine. So this is the overall survival is still not built benefit. But the important thing is, PFS, as I mentioned, Pola R-CHIP is 27% reduction in risk of progress, relapse, or the death. This is a huge number. This is, again, I mentioned, this is now more than 2.5 to 3 decades. This is first time any trial in the DLBL, they have shown also benefit, 6.5% improvement. This is a huge improvement. Now, POLARIX-MET is primary endpoint, which is statistically significant, meaningful improvement PFS in patients with the previously untreated DLBL. Pola R-CHIP resulted in 27% reduction of the risk of progress, relapse, death versus R-CHOP without any toxicity. So what it impact POLARIX study, I think the Pola R-CHIP will demonstrate, which is, as I mentioned, 27% reduction risk of progress, relapse without significant toxicity. This may be paradigm shift in the few years they will put in the guideline. As the POLARIX is the first trial over 2 decades which I mentioned, meaningful improvement benefit risk benefit versus the R-CHOP in a phase 3 double-blind randomized control trial. It demonstrates the positive benefit risk profile, 27% reduction in progress and death, and the global correlation with the LISA and other science world has lead to significant enhancement of the patients. So after this, I will go again, challenge 1 done. Now challenge 2, there is 63-year male who has stage 3B DLBL and with significant weight loss and significant B symptom, very high LDH, performance status is 1, only background is hypertension, ejection fraction is 60%. He had IPI score is high. So what do you think now you have learned? So his options of therapy are what? Do you think, because as per NCCN guideline, either R-CHOP or experimental. So you have these things, you have seen lenalidomide or Velcade, they have not given any benefit, and autologous cannot give any benefit. The only thing is left is Pola or CHIP. Is this is good for this patient? I will start at the first line. So now going to another challenge, 34-year female, stage 4A DLBL with high LDH and two extranodal sites, kidney and lungs, diffuse endolopathy, again, intermediate high IPI score, again, what are her option? Again, you will not give standard, you have to give either clinical trial you available, or you can give the next standard which are upcoming. And this is, there are 4 regimens, and you have seen which regimen is giving benefit of the PFS, 25% reduction of the progress and death. POLA or CHIP is the standard. So I think we'll give to this patient this one. So in second last slide, which I want to show how I adopt my frontline therapy and DLBL approach when we consider changing, as I say, I have gone through A to G. So this is my bonus question. What do you think in last 3 patients which I presented the challenges? I hit the disease, I heard the patient, I hit the disease accordingly, the protocol which are available. So in the last 20 minutes, I have gone through eye opener, future production, diffuse large B-cell lymphoma, challenges and solution. We had 2.5 years, 2.5, sorry, decades. We have challenge which is solved by now POLA chip. We have now new first-line DLBL therapy as per ASH 2021, which is mentioned, POLARIX pivotal trial, which is published in the New England Journal. This is the advantage of the POLA, is the reduction of the 27% of the disease progress and death. So my question is, how do you predict in 2022 and 2025, if you have a high IPI score? So this is the closing question. What do you choose? You will choose what, if you don't have available clinical trial, you choose R-CHOP or dose change R-CHOP or EPOCH or R-CHOP with autologous transplant, or you will choose POLA or CHIP CHP without vincristine. Thank you very much. If you have any question, I'm happy to answer you.